Ma'am, please start.
Good evening and Happy New Year 2025. This is the year of artificial intelligence. Information and knowledge studied for years together with clinical expertise will get an advantage of science of probability. This is a welcome addition, like our journal journey now is rising up to the next level of excellence. We are very fortunate to have super specialty to share their wisdom for the general pediatricians of periphery like me. Sone pe suhaga. And may I invite Raigad IIP star member Dr. Neha Singh for further formal welcome. Over to Dr. Neha.
Thank you, Chitra ma'am. A very good evening and Happy New Year to all. On behalf of Maharashtra IIP as well as Raigad IIP, I, Neha Singh, welcome you all for today's journal journey. As we begin this new year, let's embrace it with positivity, curiosity, and a commitment to growth. Today, we are very fortunate to have with us dignitaries from Central IIP, Maha IIP, as well as other state and city branches. In absentia, I welcome our Chief Guest and National President, Dr. Vasant Halatkar sir. I also welcome our new Maha IIP President, Dr. Sanjay Pakmore sir, Maha IIP Secretary General and Central IIP EB, Dr. Amol Pawar sir, Dr. Sanjay Deshmukh sir, Maha IIP Past President, Dr. Hemant Gangolia sir, as well as all the respected executive board members from Central IIP and Maha IIP. I also welcome Raigad IIP President, Dr. Vikas More sir, Secretary Dr. Ajay Kohli sir, our patron, respected Dr. Neeman Mohanty sir, and all the members from Raigad IIP as well as other branches. I also welcome our esteemed experts of today, Dr. Tushar Godbole and Dr. Vishram Bhuche sir, as well as our presenters, Dr. Hari Mangtani and Dr. Ashish Lote sir. So now I request Dr. Hemant Gangolia sir to kindly unmute and give a formal brochure of the journey of the journal journey.
Thank you, Madam Dr. Neha. At the outset, happy and prosperous New Year 2025 to each one of the respected dignitaries on the Zoom dais of Journal Journey and respected viewers and IPNs attending this webinar. IIP Raigad is known for its innovative ideas and trendsetter programs for almost last 5 years, and the Journal Journey is one of them. Well, the concept of the journey was the brainchild of myself, Dr. Jay Bhandarkar, our mentor, Dr. Neeman Mohanty sir, and Dr. Chitra Kulkarni madam. The first episode was started on Doctor's Day, 1st July of 2021, by the first ever Lady Cabinet of IIP Raigad branch, and probably the first of its kind in our country under the presidency of Dr. Sunita England and Secretary Dr. Nilima Bhandarkar and IIP Raigad team. The concept came from the memories of our PG days when there used to be journal club, journal reading. Therefore thought, why not to start with the practicing general pediatrician presenters and the experts. Since then, it went across the districts of Maharashtra, then the states across the country. First day of every month for last 3.5 years, we had this webinar of Journal Journey. The program, which was started by IIP Raigad branch on Doctor's Day of year 2021, was taken up in association with Maha IIP under my presidential tenure of the year 2022. Heartfelt thanks And thanks a lot to then the incoming presidents, Dr. Ramakant Patil, then Dr. Ram Gopal Sezara, and now Dr. Sanjay Pakmode sir, along with the ECMEV Secretary General Dr. Amol Pawar and their team to continue their prestigious program during their tenures. Thanks a lot to each one and all the cabinet members and the EB members of these MAHAIP teams. Heartfelt thanks to all CIP presidents, then Dr. Bakul Parekh, Dr. Ramesh Kumar, Dr. Upendra Kinzavdekar, Dr. G.B. Vasavaraja, Dr. Vasant Khalatkar, and HSGs, Dr. G.B. Vasavaraja, Dr. Vinit Saxena, Dr. Yogesh Parikh, to grace the occasion for the first episode respectively in their tenures, either as a president or as a president-elect. And once again, today we have Dr. Vasant Khalatkar sir in absentia, the chief guest for today's webinar as a chief guest.
Sir, Vasant sir is there. Vasant sir is there.
Welcome, sir. Welcome, sir. Thank you very much, sir, for gracing this occasion, as well as CIP Secretary, Dr. General Secretary, Dr. Yogesh Parikh, sir. We as IIP Raigad are very fortunate, and we have proud feel that day one of each year, 2022, 2023, 2024, and now 2025 as a stepping stone for each of the CIP as well as MAHAIP presidents, secretaries of their years respective to start their journey with this General Journey episodes from the day one of their offices. Thank you each one and all for all your support and help. All the best wishes for the year 2025 for the journey of General Journey as well. Thanks a lot to the strong pillars of this program, Dr. Chitra Kulkarni Madam, Dr. Neha Singh, technical team under Madam Pallavi Dharmadhikari, last but not the least, the then President Secretaries, Dr. Pramod Wankhede sir, Dr. Vikas More, Dr. Dhananjay Rajput, Dr. Ajay Kohli, and the IIP Raigad cabinets of their respective teams. Wish each one and happy learning, and welcome the EB member Dr. Sanjeev Joshi, I can see, Dr. Mina Sheikh, as well as all the office bearers of this.
Thank you, sir.
Thank you so much. Thank you so much, Gangolia sir. And now I welcome and request Dr. Vasant Khalatkar sir to please give his blessings for the new start of the journey 2025.
Namaskar. I wish you all the best happy new year. Respected Dr. Hemant Gangolia, our President Dr. Sanjay Pakmode, past President Dr. Chejara, Dynamic Secretary Dr. Amol Parekh, all the members, Dr. Chitra Kulkarni, Neha Singh, Raigad people, really, this I think since last 1 year, I attended this 4 times journal journey, and really it's going on well. That I know this is so there you people are so passionate and perseverance is so good that एक तारीख भी छोड़ा नहीं है. I know most of the you members have enjoyed 31st, and in spite of all that 31st you are still live. That's a beginning. Once beginning, that's half of the done, half of the thing done. So I know this will be a different thing, and making a journey of journal is really required passion. Initially, we know in our college days it was very difficult to get the journal, present it, and that was journal classes were going on. But that time we had a limitations, and but now everything is available. But who look it? That's why nobody is going for that internet and looking up there so many journals, but they want to have a thesis. आजकल thesis भी खरीदे जाते हैं. So this should not be done. That's why this journal journey you are doing a tremendous and great work. I wish all the best to team Raigad and Maharashtra IP.
Thank you, sir.
And this your journey should be continued. Wish you all the best, and once again, Happy New Year. Thank you.
Thank you so much, President Sir, for finding time from his busy schedule and showering his blessings to us. Now I request MAHAIP President Dr. Sanjay Pakmode sir to please give his blessings for the new start.
Good evening, everyone. I wish you a very happy and prosperous new year. Today's chief guest, Dr. Vasant Khadatkar sir, President 2025, which is going to be installed soon after a week. Past President Maha-IP 2022, Dr. Hemant Gangulia sir. Then the Mohanty sir, academician, the academician and the mentor and the advisor for so many academic activities. I welcome you, sir. And all the CIP EB members, Dr. Sanjeev Joshi, sir, Dr. Rajesh Kulkarni, sir, and other members who have joined in their absentia. And then our secretary, dynamic secretary, Dr. Amol Pawar, and Team Raigad branch. I must congratulate you for when I was going through the last few years academics, then I found that's journal journey, which is to be held on the first of every month. And then when I thought ki first Jan, so I found it is a very difficult first Jan. Then I could see that commitment and sincerity of IAP Raigad branch, Chitra Kulkarni madam, Dr. Neha, and Chitra madam contacted me well in advance 15 days back, and she said, are we going to continue journal journey? I said, madam, yes, we are going to continue journal journey. And since then, madam was in touch with me every time. She was asking who will be the presenters, who will be the experts, who will be the chief guest, and everything. In the morning, ma'am, one call or either good morning message she used to give to me. This is arranged, this is not arranged. Then that taught me in last 15 days how means the sincerity. I mean, I learned a lot of in the last 15 days from them, how sincere and committed they are. So this program is running in 22, was continued by the president of 23, Maha-IP, and was also continued by the president 24. And I'm fortunate enough to continue this particular program of journal journey in my tenure of 2025. Really, ma'am, hats off to Chitra ma'am, Neha ma'am, and your mentor, Dr. Hemant Gangulia sir, and the whole Raigad branch. I'm really, obliged to you because continuing such a good program, and that too on the very first day of the year, and that gives me immense confidence in continuing so many activities in the year. And since it is continued on the first, so I think all the 12 months will be included in it. So there will be the 12 journal journeys where we can include so many presenters as well as experts. And so this will be a good academic fest for the every Maha-IPN. So I think, thank you, ma'am, for your association and your help every time. For today, we could make this possible on the very first day of the 25. So thanks once again. Over to you, Neha, ma'am.
Thank you, Sanjay sir. Now I request Maha-IP Secretary General Dr. Amol Pawar sir to say a few words. Yes.
Thank you, Neha. First of all, welcome our chief guest. He might have left because there is another meeting for him, the EB welcome meeting today. Then Dr. Sanjay Pakmude sir, President 2025 of Maharashtra IIP. My President in 2022, Dr. Hemant Gangulia sir. Then Dr. Niman Mohanty sir, the main pillar. And then along with Dr. Hemant Gangulia and Dr. our Jay Bhandarkar sir, then later on Chitra ma'am, Neha, they all are working very hard for the success of this journal journey. And a lot of PG students, a lot of experts, presenters, they got to know what the real chunk of this journal journey through, and they have in last 3 years, they also have taken efforts in preparing various topics under the guidance of Niman Mohanty sir, all the trials which the Dr. Chitra ma'am, Dr. Neha, Dr. Niman Mohanty sir were part of. I have seen in last 3 years the efforts they took for the success of this journal journey. This year also, Dr. Pakmude sir consented to continue the same thing. So I thank today's presenters, Dr. Ashish Lothe sir, Dr. Then our Dr. Hari, and also experts who have taken efforts in guiding the presenters, Dr. Tushar Godbole from Nasik and Dr. Vishram Buche sir from Nagpur. So I wish all the best for this journal journey. Thank you. Thank you, over to you Neha, again.
Thank you, Amol sir. Now I request Dr. Raigad IP President, Dr. Vikas More sir.
Yeah. Thank you, Neha, for giving the opportunity. And at the outset, I'm so much thankful to Dr. Vasant Kaskar sir for being consented to be a chief guest of this important session. And there's a very good sign that on the first day of a year we are meeting. So this is going to be a very strong journey for coming 1 year under the very strong leadership of our new president, Dr. Sanjay Pakmode sir. Well assisted by Dr. Sanjay Deshmukh sir, and obviously my very good friend Dr. Amol Pawar, who is guiding and helping us since last 2022. So this is my third year as a Raigad president. So I'm witnessing the three presidents back to back, and everybody is so graceful and kind enough to support us to continue this journey. I am like Marathi मध्ये म्हणतात ना आयत्या बिळावर नागोबा sort of. So I'm a president, but I am getting the credit of my team because they work very hard. And as a president, I get the credit. But it is with due respect, Iman Moti sir, Chitra Kulkarni madam, and Neha, they are working very hard to continue this journey. And as a Raigad IIP, we are supporting them. But to whole Maharashtra IIP, they bless us like anything. All CIIP members, Sanjay Joshi sir, Minar sir, everyone, Rajesh from Pune, everyone helps us, blesses us to continue this journey. Please bless us. And if any mistake from our side, please let us know. And thank you so much for all. And I pray to the Lord that this journey will continue for the long, long time. Thank you. Over to you, Neha.
I forgot the name of Vikas More sir, President Raigad branch, and Ajay Kohli sir. I'm thankful to both of you.
Thank you. Thank you. Thank you.
Thank you.
As well as welcome Dr. Praveen Gokhale sir.
Praveen Gokhale sir.
Yeah.
Good evening.
May I request Dr. Sanjay Deshmukh sir to say a few words?
Ma'am, I cannot see him.
Yeah, he's there.
Yes.
Dr. Sanjay Deshmukh is there.
Sanjay
Sir,
Deshmukh.
please.
Good evening, Vishram sir.
Good evening, everybody. Respected President CIP, Dr. Vasant Katkar sir, and President Maha IP 2015-20, Dr. Sanjay Pakmode, Dynamic Secretary Amol Pawar, CIP Honorary General Secretary Dr. Yogesh Parekh in absentia, all past presidents, Dr. Hemant Gangulia sir, Dr. Ramakant Patel is not there, Dr. Ramgopal Chejala sir, and the dynamic and academically active IIP Raigad team. The words are less for me because on the day first of New Year, it's very difficult to catch all the academicians on the platform after hectic New Year celebration. But I think that's the best way to begin the journey of any association. And rightly said by Dr. Pakmode sir, it will boost the confidence of the new team. So no matter how the show must go on. So thanks to IIP Raigad team, and I hope in this year, Dr. Sanjay Pakmode, Dr. Amol and his new team, along with the support of all Maha IIP branches, they have innovative ideas to promote the academic at every level. So thanks to everybody for giving me this opportunity, and my best wishes for the this general meeting, and congratulations to all the participants. Thank you very much.
Thank you, sir.
Thank you, Sanjay sir. I also acknowledge the presence of Dr. Minar Sheikh sir, Dr. Jitendra Gawane sir, then Dr. Sanjeev Joshi sir, and Dr. Vishnu Birazdar sir.
Praveen Gokhale.
And Dr. Praveen Gokhale sir. I welcome all of you. And our first expert for today is Dr. Sir, please share the slides. Our first expert for today is Dr. Tushar Godbole. Sir is a pediatric and adolescent endocrinologist, associate professor at Dr. Vasantrao Pawar Medical College and Hospital, Nasik, also director at Harmony Health Hub, Nasik, visiting consultant and Sambhaji Nagar and Dhule. Sir has book chapters in his name at Ghai's Textbook of Pediatrics, IIP Textbook of Endocrinology, and PG Textbook of Pediatrics. He has 5 national and 5 international publications. He has been executive board member of ISPA 2015-16, 2019-20, editor of Maha IP Bulletin 2015-16. Our second expert for today is Dr. Vishram Bhuje. Sir is chairman, Academic Council, New Era Mother and Child Hospital, Nagpur, also ex-national chairman, Pediatric Intensive Care Society, Pediatric Intensive Care Ratna Award has been given to him. Our first presenter for today is Dr. Hari Mantangni. Sir is DNB, done his DNB Pediatrics from Jahangir Apollo Hospital, Pune, ICU registrar at Jaslok Hospital, training and fellowship in pediatric endocrinology from Bharati Vidyapeeth, and he has been lecturer at Bharati Vidyapeeth Medical College, Pune, ICMRCC in medical genetics and genetics counseling at Department of Medical Genetics at SGPGI, Lucknow, fellowship in pediatric endocrinology at Alter Hey Children's Hospital, Liverpool, England, UK, and awarded by the European Society of Pediatric Endocrinology. Sir will be presenting the case Obesity Post-Pandemic Weight Management. Our second presenter for today is Dr. Ashish Lote. Sir is Professor, Department of Pediatrics, GMC Nagpur, fellowship in neonatology and PICU at Australia, advanced NRP and PALS trainer he has been, and multiple research publications he has, various presentations in national and international conferences, and he will be presenting the paper Trends in C-reactive protein used in early onset sepsis evaluations and associated antibiotic use. So now I welcome Dr. Hari Mantangni sir to share his slides and start the session.
Thank you so much, and I would like to thank Maharashtra AP for giving me this platform. Without wasting any time, I'll just start sharing my screen, and I hope I am visible as well as audible. So I'm sharing my entire screen, and so I'll be presenting about obesity. And post-pandemic, we have all seen a rise in the incidence of obesity in pediatric age group. So both childhood and adolescent age group we have seen. So this article of Obesity Post-Pandemic Weight Management by Professor A.M. Swami was there. She's a professor at West Virginia University, USA. And it was published in Pediatric Clinics of North America, volume 71 in 2024. It has got an impact factor of 2.12 as per 2014, and it is published bi-monthly by W.B. Saunders from US. So we have experienced this corona virus disease. So we were all into that pandemic together, lockdown at home. And with this reduced activity, increased exposure to television and all, we had an increased incidence of adolescent with obesity. And we all know that obesity has an increased risk of complication from coronavirus because they are more likely to require respiratory support. Apart from that, metabolic consequences and negative impact are there, particularly negative body image and low productivity has been noted. And that's why early intervention are warranted to reduce negative health effects of this obesity. So let me create a background of obesity. It is defined by WHO in 98 as a condition of excessive body fat to the extent that the health and well-being are adversely affected. So we're talking about the body fat here, and we know that it's a central or intra-abdominal fat or visceral fat, which is more pathogenic. And we as South Asians have a special status. So for the same percentage of body fat, we are more prone or we are more likely to develop metabolic complications than the rest of the world. So percentage of body fat, which is also called as adiposity, is dependent on weight, height, age, sex, and pubertal status. So these are all factors which are responsible for defining body fat. Though BMI is one of the clinical parameter we use to define obesity or and overweight, but that has got its own limitations, because to know the percentage of body fat, DEXA scan is the most appropriate thing to do. But we take BMI as a surrogate marker. So coming to obesity and its consequences, obesity is a risk factor for later heart disease and other chronic diseases, contributing to increased mortality, morbidity, as well as poor quality of life. So what are the complications we are looking at is increased insulin resistance and development of metabolic syndrome and type 2 diabetes, hyperlipidemia, which includes hypercholesterolemia and hypertriglyceridemia both, early development of atherosclerosis secondary to hypertension. Apart from this, we have got asthma and sleep apnea developing, or obstructive sleep apnea. And these obese kids, they later may develop orthopedic and musculoskeletal complications. Females in particular, they are more prone to develop polycystic ovary syndrome. So introducing the journal, pediatric healthcare providers, they have observed increase in the children and adolescent weight and BMI, and the prevalence of obesity has been increasing. This all of us must have come across. So what are the main contributors is increased consumption of calorie dense food and more of a sedentary lifestyle, particularly during the lockdown when there were closure of schools and public places. And we have transitioned from the online learning and increased screen time. So apart from this, the additive effect of the negative impact of the social media has also created a lot of issues. So the American Academy of Pediatrics clinical practice guidelines were published in February 2023 for evaluation as well as treatment of this obesity or pediatric obesity. So it promotes what it tells that it promotes considering the person or the child as a whole, along with the family and social background, when we are planning evaluation and developing treatment plan. So we have to check the child's attitude, the family attitude, the social background from where the kid is coming, and then planning the evaluation as well as the treatment plan. So there is no written protocol which one has to follow. We have to change it accordingly depending on what information we get from the patient and the family. And it suggests that every patient should have an intensive health behavior and lifestyle treatment for at least 26 hours in 3 to 12 months of period. And in addition, treatments may include pharmacotherapy as well as bariatric surgery, depending on the age, the BMI, and the comorbidities, whether they are present or not. Now, this is a new concept of motivational interviewing, and it is a conversation strategy to help build the therapeutic relationship. So first thing is to develop a relationship or rapport with a patient so that we can guide them better. It suggests that we should not be a judge and tell that you are eating wrong or your lifestyle is wrong. You have to just guide them that where they are actually faltering and what they should do. So the conversation is intended to understand the patient's motivations and values, as well as the reason for following or not following any particular set. So we may not tell him to join a gym or go running, because we have to know the social milieu or where the child is living and in which family, whether it's a joint family or a nuclear family. So there are many factors which come along the way of treating such kids. So, however, it was recognized that the motivational interviewing, it reduces the intake of sugar sweetened beverages, but it did not have much impact on BMI or body composition. So once coming across a child with obesity, what are the points or what are the things we should evaluate? The guidelines suggest that a clinical and biochemical screening for comorbidities include fasting lipid panel, hemoglobin A1C, liver function test, particularly alanine transferase, and blood pressure at each visit to screen for hypertension. Additional tests should be based on history and examination. Particularly in females, we search for stigmas of polycystic ovary syndrome. Relevant X-rays are to be done if there is history suggestive of limping or gait abnormality. And similarly, as it is known that a negative body image is created in kids, and we should act. They may have anxiety or depression, or may have general disorder of eating. So a validated questionnaire should be used to diagnose such a thing. Coming to the management plan, the primary goal of management of obesity is the prevention and remission of comorbidities. So we should prevent development of comorbidities, and if it has happened, we should try to help them reduce the comorbidities or decrease it. So evidence show that loss of almost 5 to 10% of total body weight can improve obesity related morbidities. Now, what are the strategies which are include? One is intensive lifestyle intervention, which will be based on food or food intake, calorie intake, diet, exercise, lifestyle, screening time, and all other things. Other is anti-obesity pharmacotherapy, and third is bariatric surgery. So in adolescent with class 2 obesity with significant comorbidities, or in those with class 3 obesity, whether the comorbidities are there or not, one can offer bariatric surgery. So coming to therapeutics, FDA has approved these medications for obesity. One is orlistat, other is phentermine and topiramate combination, and third is this liraglutide and semaglutide. So SGA semaglutide is most effective and well tolerated, except for weight regain following its discontinuation. So it's a chronic medication which has to be taken. It's GLP-1A agonist, and its use is limited by availability and cost. So it is not freely available, and cost is also high. So a combination of phentermine and topiramate therapy can increase the risk of suicidal ideation and slow linear. So not very popular among pediatricians or pediatric endocrinologists. And orlistat, it prevents absorption of oil and causes this oil to pass in the lower GI tract, and that's why it has got intolerable gastrointestinal side effects. So not actually used very commonly. Surgical intervention, there are 3 procedures which include vertical sleeve gastrectomy, Roux-en-Y gastric bypass, and adjustable gastric banding surgery. So bariatric surgery, it yields almost average weight loss of more than 25%, and that is sustained over a period. So sustained weight loss and remission of comorbidity. That is a very important outcome of surgical intervention. Long-term complications of bariatric surgery include weight regain if the patient is not following the particular diet, and vitamin deficiency. So these patients who have undergone surgical intervention, they are expected to adhere to a particular eating pattern. Because the capacity of the stomach is smaller, they must take proper supplements, as well as they should follow a particular eating pattern. Out of all these 3, vertical sleeve gastrectomy is the preferred procedure in adolescent. Coming to the Indian scenario, we know India is a fast-growing economy, and we are currently undergoing major epidemiological, nutritional, demographic transition. And these transitions, they are all promoting obesity in almost all age groups, not only kids, not only adolescents, but all age groups. And the prevalence has increased of overweight and obesity. It's been variably reported. Has been to 3 to 14% of obesity, or 6 to 22% of overweight. But the most important or unambiguous statement is overweight and obesity rates in children and adolescents are increasing. There is an emerging global epidemic, and that will have a profound public health consequences. So it is important to plan an active intervention. See, as a pediatrician, we should be more focused because we are catering, and soon these kids will become the future of our nation. So we have to have an active intervention, which is better than wait and watch approach. So most important take-home message for us, for pediatricians, is we should be actively looking for a child with overweight and obesity, Checking anthropometry, BMI, and plotting it on the appropriate chart is a good screening method. So one should start using these charts, which are freely available or easily available on IAP websites only. Once they are picked up, once such kids we have labeled it or we have picked it, then they should have a clinical and biochemical evaluation for the presence of comorbidities, as this list of comorbidities we all know. And the parents, patients should be counseled. We should take the responsibility of counseling them, encouraging them for at least lifestyle intervention, cutting down on calories, reducing the screen time. And of course, resistant cases or syndromic cases, they require referral to a pediatric endocrinologist. So to summarize my presentation, this article gives an overview of obesity management in the post-pandemic landscape. It suggests using motivational intervention to interview to discuss this sensitive topic, because some kid might not like to be called as obese or overweight. A non-judgmental approach is vital to form a therapeutic relationship and relationship with the patient to guide them towards lifestyle intervention, particularly the parents. So we should have a good relationship with not only the child but the parents also. And we should be using shared decision making when setting goals and developing a plan of care. So what the child can do easily and what parents can follow easily, we should have that decision making, and we should involve the whole entire family if possible. Pharmacotherapy and pediatric surgery, they are options, and they are very effective options in reversing comorbidities in selected if patients are selected carefully. So with this, I would like to thank you all for your patient listening. I'll just stop sharing my screen.
Thank you. Thank you very much. We are very fortunate to have a pediatric endocrinologist as a presenter, and another little senior but young Dr. Tushar Godbole, pediatric endocrinologist, to have the comments about this paper.
Thank you, Dr. Chitra. Me and Hari are contemporaries, and it is in fact Hari's big heart to offer me to be the expert for this session. He is as good as an expert.
Yes.
So Hari, thank you very much for this presentation. It's indeed very difficult to present a it's not an RCT, randomized control trial, or intervention trial. So it's for those papers, it's very easy to present methodology and results, etc. But for a review article, it's very difficult to summarize it for a journal journey. So first of all, congratulations for doing justice to this,
Thank you, Tushar.
this article. Indeed, it's a very practical article for pediatricians. And I mean, I went through the article a couple of times and I found it very, very useful. And another useful article is the IAP Guideline 2023. I hope all of you have, the listeners have gone through. I have a couple of questions to Hari, if you can throw light on that. So
Yes.
you mentioned for pediatricians, the review article recommends HbA1c lipid profile, SGPT. What would be your comment on serum insulin? Because many of us, I never do serum insulin as a protocol, but I have seen pediatricians doing serum insulin levels. So what does the article say about it, and what would be your take on doing serum insulin levels?
So coming to insulin level, serum insulin level, this article does not mention any particularly whether the insulin level should be measured. Second, measuring insulin was done to check for HOMA-IR. So homeostatic index of insulin resistance was calculated by multiplying the blood sugar level. So isolated insulin levels does not help. If we are checking for HOMA-IR, we have to take simultaneous blood sugar level and fasting sugar level, fasting blood sugar multiplied by the insulin levels taken simultaneously divided by a figure of 405 gives us a HOMA index. And there are various cutoffs for childhood 2.5 and adolescent at 4.5 to diagnose insulin presence or absence of insulin resistance. But additionally, we have got so many other parameters like presence of acanthosis nigricans and other issues of insulin resistance, like development of type 2 diabetes or high HbA1c. So all these parameters taken together, we should focus more on these rather than, I think, insulin Plus, measuring insulin is not, it's a labile molecule, and C-peptide, which has got a higher half-life. Many people, they do it. But I don't think it will add to any kind of, it will add much more to what we are already doing. So
Perfect.
that would be my take on
Yeah.
it.
So a quick comment for all pediatricians who are listening to this. So, as pediatricians, when you are evaluating any child with obesity, please remember to do a fasting sugar also, because it comprises of the one mandatory pillar for the metabolic syndrome. So, in addition to your central obesity, you have fasting sugar, the lipid profile with the triglyceride and the HDL, high TG and low HDL, your blood pressure. So these out of four parameters, so HDL, the triglyceride, fasting sugar, and your blood pressure. So four plus your central obesity. So pediatricians need to remember to document blood pressure and also do a fasting sugar in addition to lipid profile. Um, uh, Chitra madam, there are some questions in the chat box. Do we take them now or do we take them in the end?
Sir, please later on, let the second, and then we are having separate time for question answers.
I'll make that the degree of metabolic syndrome also correlates with the degree of obesity correlates with the degree of metabolic syndrome. So that pediatricians should know that it's not just the obesity, but the degree of obesity. And Hari correctly pointed out that the class of obesity, class 2 and 3, one has to, keep remember the degree of obesity while evaluating. Yeah. Thank you.
Yeah, thank you very much. Now, may I request our second presenter, Dr. Ashish Lothe, sir, to present his topic of CRP.
At the outset, let me thank Maha AP for giving me this opportunity to present this topic. So today's topic is trends in CRP, which is very close to every pediatrician's and the neonatologist's heart. Right. So, in next 12 to 15 minutes, we'll through this journal's insight, we'll look at how the trend of CRP has been changing. CRP use has been changing by various institutions. And then we'll do critical appraisal of this journal article using stroke guidelines. And in the end, we'll see what are the key messages arising out of it. So the title of this journal article is Trends in C-reactive protein Use in Early Onset Sepsis, Evaluations and Associated Antibiotic Use. This has been published very recently, October 2024, an original article, the Journal of Pediatrics. It's a monthly international peer-reviewed journal, highly reputed journal, indexed in PubMed and Scopus. Its metrics, its impact factor has been very, very good. For last 5 years, it is 4.4. For 2023, 3.9. IGN factor score is very good, 0.02. Journal also has a Scopus site score of 4.9. The original article, volume 213, published in October 2024, and can be cited as following. Multiple authors. So introduction, as we know, CRP is a commonest biomarker used in the diagnosis and evaluation of suspected neonatal early onset sepsis, EOS. It screens the babies for further investigations like evaluation with blood culture, other markers, even antibiotics. It also determines treatment duration. How long do we continue IV antibiotics? But each center has its own specific policy for CRP, as it is a very less sensitive, less specific. So in United States, they found that lesser centers are using. So there is a change in the CRP usage by various centers. So recognizing this variation in CRP use by the centers is highly relevant because it impacts the management. The patient outcome is different because CRP on one hand uses for proper guiding neonatal EOS management. Conversely, it also leads to prolonged antibiotic use and starting initiation of IV antibiotics. So objectives of this study were to determine the prevalence of CRP use in EOS evaluation across the United States, to estimate the changes in CRP usage over time, and to determine the association between CRP use and antibiotic usage. Coming to methodology, materials and methods. So study design was a retrospective cohort study, quite interesting. They went back in time and then studied a cohort in some hospitals of United States, followed it up prospectively over the period of 2 years. That's a quite a lengthy study to determine the impact of the study. 2009 to 2021 from electronic records of those hospitals. So quite a long duration, and the design is a strong cohort study. The setting was it was a multi-centric study of centers contributing to the data of Premier Healthcare database. That's a database of patients hospitalized across United States. There are 857 centers catering to more than 1 crore infants, but only centers where NICU admissions were occurring from day 1 to day 3 were taken. So 735 NICUs and a population of 13 lakh 87,000 new units was taken. And they took high volume centers. So less than 50 annual inborn NICU admission centers were excluded, and 6 centers where blood culture wasn't done were excluded. So in the end, eligible centers were 572, catering to 13 lakhs 43,000 of neonatal population. So this was done in the divisions of neonatology in the states of Philadelphia, Pennsylvania, Drexel University, and Stanford. So exposure group, the neonates in where blood culture was done from day 1 to day 3 and CRP was done, those neonates were selected. In the study populations, infants undergoing EOS evaluations was defined as those neonates with at least one blood culture charge on day 1 to day 3. From day 1 to day 3, any time after birth. Center CRP usage was calculated as annual proportion of infants with a CRP charge on day 1 to day 3 among infants who had a blood culture on day 1 to day 3 after birth. So depending upon the proportion of units with blood culture, CRP done. So if we consider 100 babies with blood culture taken, so if we do in 25 babies or 50 or 100, so depending on that proportion, use rate, 4 categories were devised. So low use, so less than 25% times CRP was done. Medium to low use, 25 to 50% of babies CRP was done. Medium to high use of CRP, 50 to 75. And high use, more than 75% neonate CRP was done. So accordingly, based on this proportion, these 4 categories were devised. So we can see this flow chart. So study population, after all inclusions, initially 857 centers, then NICU centers catering to admissions of day 1 to day 3 neonates, 735 centers, 13 lakhs babies. Those centers were excluded, less than 50 admissions and no blood culture. So eligible population 572 centers and 13 lakh population. So sorry. So 436 centers. So accordingly, low, medium, and high usage centers were devised. Those 4 categories are shown there. So outcomes. So primary outcome defined, studied were frequency of antibiotic initiation on day 1 to day 3, antibiotic administration for more than 3 continuous days. So starting of antibiotics was studied, as well as prolonged early antibiotics was also studied, and mortality in less than 7 days after birth. Secondary outcomes, frequency of EOS evaluations, early onset sepsis evaluations, use of antibiotics other than ampicillin, gentamicin, or penicillin, antibiotic initiation on day 4 to day 7 after birth, length of NICU stay, and mortality. during hospitalization and transfer less than 7 days after birth. These were outcome studies. So because of the lengthy study and multicentric, lot of statistical methods were done. So if we discuss statistics, it itself will be a single class in itself. But major statistical methods used was CRP use prevalence was studied. It was calculated as proportion of NICUs in each category of CRP use. Generalized regression model was studied to discuss association between high CRP use and the study years. Center making greater shifts in CRPs, like if they were in using low use, and next year if they are going to go high use, so that's a more than one category shift on CRPs. Those were excluded, and multivariable adjusted regression analysis was done to account for differences in so many centers, 400 and 530, more than 500 center, and such a huge cohort of neonates, patient and center characteristics. Outcomes distribution were compared using Kruskal-Wallis test, and for antibiotic association, the sandwich model was studied later on. So, coming to results, so total of 572 NICUs and more than 13 lakhs neonates were study population. So one of the major result finding was CRP use was variable across centers and also across study years, whole duration of 12 years. So CRP usage differed center to center and even over time in same center. CRP tests obtained in low use centers were 4%. So out of 100 babies in whom blood culture was taken, only 4 babies, those centers did CRP. In high use centers, 96% in 96% babies, CRP was done. High CRP users significantly decreased in 21 compared to 2009. So when they started study, the usage was 24% CRP usage, and it dropped to 17% in 2021. Low CRP users significantly increased in 21 compared to 19. So 47% to 64% of all neonatal population. So that's a huge rise in low CRP users. 86% continue to use CRP at low levels. So out of more than 500 centers, 436 centers continue to have low CRP usage. Only 2.9% jumped from low use to high use. So that's a minuscule proportion to change from low use to high use. So compared with low use centers, a greater proportion of high use centers obtained blood cultures and initiated antibiotics. So more probability of getting blood culture and initiation of antibiotics was there in high CRP usage centers. Probability for an infant to receive prolonged early antibiotics was twofold greater in high use center. So double probability in high use center to receive prolonged early antibiotics compared to low use center. And also they continued. So starting of antibiotics as well as continuation of antibiotics, both were higher in high CRP usage centers. There was no difference in mortality though in both high use or low use centers. So if we see this stacked bar diagram, so dark one is high use center and the fade one is low use. Those color codes are given there. So if you see over time from 2009 to 2021, you can see U-shaped pattern. Initially from 9 to 2009 to 12 or 13, CRP usage increased slightly. You can see all the shaded area. But thereafter, CRP usage has been declining gradually. And the low use has been rising, even compared to the initial part. And the high use has been dropping serially, that we can see. So this alluvial chart shows the shaded area. Shaded area is high use. So dark shade is high use and low shade is low use. You can see low use increased from 48% into 67% in 2021. And you can see thick shades of drop and rise of very thin shades. You can see that. So there is predominant of drop in CRP usage, high use from 24% to 14%. The alluvial chart is self-explanatory. So coming to discussion. So major point found was there is wide center variation in CRP usage for sepsis evaluation. Major trend is towards reduced use. The centers that frequently obtain CRP, that is high usage, also administered prolonged early antibiotics and more frequently. Higher proportion of infants receiving prolonged early antibiotics is in response to higher usage of CRP. So they found out that more the use of CRP, higher the frequency of antibiotics. There is no difference in mortality. So successful de-implementation of routine CRP use in sepsis evaluation without an increased incidence of morbidity or mortality. So in same period, 2009 to 2021, they found that the incidence of sepsis was same, 0.8% per 1,000 live births. So though CRP usage was dropping, the incidence has been remaining same. So thereby making the conclusion that we need to de-implement CRP usage and reduce the usage because the low usage is not affecting mortality or morbidity. Strengths of this study, very large sample size, more than 500 centers, 13 lakhs neonates, multiple centers. It's a huge cohort to follow up. That's a biggest strength. Long duration follow-up of 12 years, 2009 to 21, and very strong methodology. What are the weaknesses or limitations? The indications of antibiotic use in so many centers. So each center would be having its own policy. Those are not known. The indications of culture results, laboratory results were not available. So we cannot directly determine appropriate versus inappropriate antibiotic use because of such a wide variability. The type of protocol within which CRP results were used are not clear. The unmeasured confounder, such a huge population, so many centers, so confounding factors must have been there at center level and at infant level were not accounted for. And this database in few states of United States may not be truly representative of all the NICUs in United States. These are major limitations. So critical appraisal of this will use the stroke guidelines, which are used to appraise, do appraisal of observational study, strengthening of reporting of observational studies in epidemiology. The relevance of this paper highly relevant even for Indian setup because we use CRP so much. Research question hasn't been stated in this study, but must have been there in their original study plan. Title and abstract. Title is abstract is summarizes it well within word limit. Title doesn't indicate study design. Scientific background and rationale was clearly defined. Eligibility criteria for participants was mentioned well. Methodology clearly explained. Study design and study setting was mentioned very well. Statistical tools have been described exhaustively and quite appropriate for study. Results match the objectives. Yes, variables were clearly defined, though were not matched due to large number of centers and huge study population. Data management was appropriate and was taken from electronic database. Bias was also mentioned. Results were unadjusted and variable adjusted. Both were mentioned according to estimates and precision. Discussion mentioned key results, limitations, and strengths. And the generalizability of population was explained. Conflict of interest was also stated well. So coming to Indian context, so which is beyond the journal purview, but we'll discuss that. So the Indian population are very high users. We tend to do in more than 95% of early onset sepsis evaluation. So we need to do on this and reduce our CRP usage. We over rely on CRP usage. Though CRP has been found to be very less sensitive, it rises after 12 hours of EOS onset and reaches peak level at 48 hours. So less sensitive, less specific. It is also affected by a lot of maternal conditions. So even mode of delivery, cesarean versus vaginal affects CRP. So vaginal has high CRP. Gestation also affects CRP. Preterms have lesser values, and maternal conditions, maternal antibiotics affect CRP values. So it is less sensitive and less specific. And but US can afford to de-implement the CRP strategy, but we do not have that robust lab support. Blood cultures aren't reliable, aren't taken properly. The other markers they use, procalcitonin, interleukin levels, are not readily available. There is cost factor. But one thing is known, CRP has low sensitivity, low specificity, but we definitely can tone down the usage of CRP, not like the United States are doing, as AAP has started de-implementing CRP strategy, but we can reduce it significantly, maybe 50%. So standalone CRP has no value. Serial monitoring is the norm for Indian context. So it is helpful for ruling out infection. It may not be helpful for establishing infection. It is late, but it can be helpful for ruling out infection, serial monitoring, and we can discontinue antibiotics when serial measurements are obtained. So because the CRP has ingrained our mind, Indian mind so much, we have been taught since our PG days. So it is difficult and trickier to deinstitutionalize CRP practice. So coming to conclusion, CRP use in EOS evaluations varied widely across NICUs. CRP use also varied across time. So there has been changing trend from 2009 to 2021. High CRP use was associated with prolonged antibiotic therapy, but not mortality. Reducing routine CRP use in sepsis evaluations may be a target for neonatal diagnostic and antibiotic stewardship efforts. Thank you.
Thank you very much, Dr. Ashish Lothe, sir. And the house is open for discussion now. May I request Dr. Nimen Mohanty, sir, to give his comments?
No, expert comment on this CRP.
Yeah. Dr. Buche, sir, is not available. He had
Okay,
to
okay.
leave for an emergency. So,
Okay.
sir, what was your idea in selecting this topic for the discussion for general pediatricians? And
Yeah.
that he has beautifully stated. Our presenter has beautifully stated about that. And what is the present policy of MGM? Let us know.
Now we continue to follow that CRP as a part of the sepsis course. So we continue doing sepsis course in our NICU, and probably the other markers availability is a question in our calcitonin and interleukins are not available to us. So we have to depend on the sepsis score. And in our Indian scenario, probably we have to carry on with sepsis score for some more days uh, till the other advanced investigation tools are available to us. Why we have selected this topic, as you can see, the discussion was so lively. Everything was brought out by these experts. That's why the senior people were given this. And this obesity, see, although we are not going away from this outside the topic assigned to us, about many things are there in obesity. Those things need not be discussed in the journal club. Only we have to confine our discussion to the topic itself, which the presidents have done excellently well. And I have no other comments to extra comments to offer. Only I can add one thing in obesity is that in our population, children population here in Navi Mumbai, we have seen that in our elite schools, the incidence of obesity and overweight is as good as in our vernacular schools. It has invaded our vernacular schools also. We did a study in the Kalamboli area, and to our horror, found that incidence of obesity is about 11%, and the overweight is more only 11%, and obesity was at 7%, which was same as DPS Nerul. So the incidence is not different in vernacular or English medium schools. Then this insulin resistance. We have estimated about 11 children about insulin resistance. We found insulin's high in fasting insulin level is more a reliable marker than the ratio of obesity, abdominal girth versus transtracranic girth. It is supposed to be a sensitive marker, this ratio between these abdominal girth and transtracranic girth. But this insulin resistance is a more sensitive method which is not affordable. It cannot be done. Many parents did object in blood testing in the obesity, and we have seen that. And recently, our studies here in MGM said that the genetic markers done early, you can detect the who are at risk. And accordingly, we can give this because SN population is blamed. They were more vulnerable to the coronary artery disease. In a study about accident victims, obese children accident victims, or 15 children who were autopsized, and was at the age of 11 or 12 years, there was atheromatosis plaques were already formed there. So it is so early, the bricks are laid for the coronary artery disease so early. So we should sensitize our parents, teachers, and our children also about this obesity. That's why this topic was brought out. So it is very relevant to our general practice. It is doable in our own setting. And about CRP is a hype. We do everything. CRP is done, but it shouldn't be overused. And that was a message sent rightly to these practicing pediatricians. Thank you.
Yeah, thank you, sir. And now may I request Dr. Tushar to unmute, and he wanted to answer one question which was there in chat box.
I think let Hari answer first.
Yeah, sure.
He's the presenter. Dr. Hari, there was one question on, although not related to the article, but the question was on the cutoff that you use
Yeah.
to define pre-diabetes and diabetes based on HbA1c.
So yes, HbA1c basically it is the glycated hemoglobin. So it is applicable only to those people having normal hemoglobin variant, not on other hemoglobinopathies. That is one important thing one must understand. HbA1c cutoffs for normal is less than 5.7. 5.7 to 6.3, we consider them as having pre-diabetes, and more than 6.3, we can have such high levels in diabetes. Now, it is a age-independent criteria. That is one more thing which one should understand. So, it is not a obese child, an adolescent, or adult. The same criteria is there for each age group. More
Absolutely.
important, anemia per se has a significant role because we are talking about the glycated hemoglobin. So not only hemoglobinopathies, anemia, and we have got carriers, thalassemia carriers, and all which we don't know exactly what is the prevalence and whether the particular child is having that hemoglobinopathy or a hemoglobin condition. So that has to be taken very, I mean, with the background clinical picture.
Absolutely.
And HbA1c has got its own limitations. That the most important it is which methodology has been used to do it. Many people they do it on some card test or NIOCARD. They not very useful. The preferred method is HPLC. So these are important takeaways I would like everyone to think of before actually interpreting HbA1c. So HbA1c alone should not be interpreted, but with the clinical background and fasting blood sugar and other things, then it becomes irrelevant. More importantly, not to diagnose based on HbA1c, but for follow-up, yes, HbA1c is more important in as far as diabetes is concerned. And what important it does, or how it helps in my practice, कि अगर बढ़ के आया तो we can actually have that fear factor in the parents' mind without thinking that uh, whether it is really truly relevant or not in that particular patient. We can create that fear factor that okay, your child is now in pre-diabetes, soon he will be diabetic if you don't. So the parent become more sincere. So that is a practical thing which I don't know. Tushar, what is your experience, please?
Yeah, I agree, and it does correlate with the degree of obesity. I mean, over last, pre-COVID and post-COVID, we have seen the BMIs have gone up for the same children, and the A1Cs have also gone up. Second advantage of HbA1c is you don't need the child to be in fasting state. So if a person from long distance comes to me in the evening OPD, I can immediately do the HbA1c and send the patient home rather than asking him to stay back for a fasting sugar. So that's another advantage. But of course, you said that we should not be diagnosing diabetes solely based on A1C. One has to do a formal OGTT using fasting sugar and post glucose tolerance test after 60 and 120 minutes.
Thank you, sir. May I ask one question for obesity only? Again, like our triad of nutrition, sleep, and exercise, which we do for motivational counseling, it is having otherwise good effect also. But only thing required is to spend the time. Here, what is your advice? Like how many months we should try for this for going for a drug?
Whatever guidelines we have, the global guidelines, the European guidelines, or also the Indian guidelines, every guideline mentioned that if there are no comorbidities, no pressing needs like hypertension or diabetes associated, then one has to do a dedicated lifestyle management over 3 to 6 months before considering a drug therapy. And by lifestyle management, we need a team. It's not a single clinician's job. One has to have a team of a pediatrician, a dietitian, a counselor, and also the parents have to be actively involved. The grandparents have to come for the consultations because many times it is the grandmother that is feeding the child. So we have to sit with the family, do multiple rounds of counseling, diet recalls, and after 3 to 6 months of failed lifestyle management, then one has to resort to drug therapy.
Thank you so much. Any questions in YouTube? Pallavi ma'am?
No, ma'am. No.
Yes, sir.
One more comment,
Yes,
Chitra.
sir.
I
Yeah.
can say relate the second topic with the first topic. CRP
Yeah.
in a case of class 2 or class 3 obese child.
Absolutely.
It is better if you do a screening for the liver, ultrasound screening to look for fatty liver disease, all right. Otherwise, CRP also is a good indicator if there is inflammation associated in fatty liver disease.
The HSCRP, you mean, sir? The high
Yes.
sensitive CRP.
Yeah.
Yeah, correct.
So that we sometimes this topic it occurred to me
Absolutely.
can be related to this. Your comment, Ifni.
I agree with you. So we see in severe obesities as a part of inflammation, we see elevated HSCRPs in many children. Yeah, and as the obesity comes down, the HSCRP also comes down. You are a better judge in commenting whether we have to do in all these cases with high HSCRP. Do we also have to do B12 levels in these children?
Yeah.
Because sometimes they have associated B12 deficiency in high HSCRP.
Yeah.
The duration of pharmacotherapy in obesity.
Hari, you want to answer that?
If at all we have started pharmacotherapy, then
So the guidelines mention that at the end of 3 to 6 months, if there is less than 4% of weight loss, then we have to stop pharmacotherapy and resit with, reevaluate the child, sit with the patient, and again go back to square one and see where we are going wrong. So the recommended weight loss is 4%. If there is less than 4% of weight loss in 3 to 6 months of pharmacotherapy, then it is labeled as failed pharmacotherapy. Whatever trials we have for the obesity drugs, they are all short-lived. Some trials are for 12 months, some of them are for 24 months, but we don't have any long-term data. The GLP-1 analogs, the liraglutide, the semaglutide, what they have found out is the moment you stop these drugs, the BMI regains. So that is the data of dropouts from GLP-1 analog treated children we have. So drug therapy has its limitations. The moment you stop, if the patient is not following lifestyle, they are bound to regain the BMI.
Ashish and Monty sir, CRP may not be that useful in diagnosing, but in the Indian setting, but can it be used as a marker for recovery or serial CRP levels as for de-escalation of antibiotic therapy?
Yes, sir. Yes. So standalone has no value. Serial monitoring for stopping antibiotic therapy, it's a good indicator. Yes.
That's right.
Any other questions? Gangolia sir, Meenakshi Sheikh sir.
Yes, excellent presentation both, but just while listening to all this, I just had two questions, but may not be related to this article, but these two questions which I feel, because we talk of lot of community, right? Obesity and COVID was discussed, but what I feel today's today's fast food and all these ready-made wrappers in the markets flowing down, how can as an, because we do have here the representing IAP, so how can we stop this? Because we have all these chana, watana, shengdana shops closed, but all these vapors and this all are fluttering with all the markets, and probably that is one of the reason for obesity also. How this can be stopped, one thing. And second, related to CRP, in those days, nowadays, whenever there is a high CRP, why don't we do COVID testing? May not, it may look weird questions, but both of the presenters can answer if they want to answer these questions.
Yes.
Sir, can I,
Yes.
if you can repeat the question, there was no band, which I could not hear. What did you ask for?
One was related to obesity, may not be related to the article, but this all fast foods flooded in the
Yes, sir.
markets. And when this chana, watana, shengdana, and kurmure all have shops are closed, and these all markets having this all these wrappers across these shops, and it is has reached the periphery also. And probably that is the maybe the reason for obesity also. How we can IAP, how we can tackle them, and also can address the issue at the maybe at government level or NGO level. It is out of the context question, but this keeps on because I was
I
reading
think,
the
yes, I got it. Yes. Thank you so much for the question, sir. I think government is doing fairly good job. Nirmala Sitharaman has raised the GST on packed food, and the Sana Futana are easy to get, and packed food is costly. So that is one thing which government is doing it. But actually, what I would say, or what I to my patients, I usually sensitize almost everyone about this packed food, irrespective of the condition for which they are coming, whether they are coming for obesity or not. I just tell them you need to cut down. But the parents have also found a shortcut of giving this packed food, because cooking or making fresh food, it is like a big thing for parents now, or the mother is not available most of the time. Sometimes she is herself busy in mobile phones and all, and they give that packet and mobile phone to their own kid. इथे गप बस आता आता काही बोलायचं नाही, मला डॉक्टरशी बोलून दे. So they will invariably open that packet of chips and give the mobile to, and they give it in front of me. So I tell those parents that this is wrong you are doing with your kids.
Yes, sir.
Should not do it. Asking any question,
Yes, yeah.
you should
Yeah,
start
I
talking to the
wanted
child,
to interfere.
because the kids, they learn everything.
Yes, I ask these questions because can we, because Dr. Tushar is also there, our
Yeah.
mentor is also there, whether we can devise, we can write a strong letter to the government of India,
Yeah.
how can it be channelized through our Central Indian Academy of Pediatrics, because all the ingredients which are written on that, whether as a, I don't know how to
Yeah.
go about, but can we do that? Dr. Tushar, Dr. Neemal Mohan.
At some places they have set regulations that within some 100 feet of the school premises you cannot sell. So those rules are there, but they are sadly not being implemented. The chips are being sold inside the school. So maybe like cigarette packets where they have the photographs of those cancers, on chips packets you can put photographs of some ICU admitted children. So that's just a wild thought. But on a more serious note, we have to sensitize the schools, and it has to be a part of the school curriculum. And we can write to the individual schools. We can help them in designing their school menu to make it more interesting as well as nutritious. So I think we have to go to schools and talk about it.
Sir, CIP has already started SSS program
Yes,
in
and we
Kinjwadekar
have
sir's
done
Correct.
it.
tenure.
Yeah.
I
Kinjwadekar
can
sir's
proudly
tenure.
say
Schools
100
have gone mad. They are giving
programs.
Maggie every Wednesday.
At, at least sensitizing them to see the packet, means to see the packet, what is the sugar level, what are the energy in the calories. At least that can also tell them and sensitize them whether to eat it or not it. Mothers as well as the children.
Young parents, at least when after their marriage, they should be sensitized rather. By increasing tax only, say alcohol use has not come down, the cigarette smoking has not come down by increasing
Absolutely.
tax. So that was the thing. We have to, prevention is better than cure. Who has westernized our diet? No fibers, nothing. It we the parents, we have done it. Who has brought those fancy food to home? Who has introduced with them? So these, we are the culprits. If you fight with you can't fight the IAP cannot fight with the industry. They'll bounce upon you, or all our conference will be stopped by hook and crook. So these big gangs are working on it. So rather, it's a social movement at grassroots level. We should rather sensitize and show the horrible consequences of this outcome to our young parents who are getting married. Everybody should get a literature, actually explaining the basic things of how to stop all this.
Yes, thank you very much. And it is time to have concluding remarks. Dr. Mohanty sir, will you please announce the February topics?
No, I'll take 2 more days. I am still searching good topics which are relevant to us. So give me 2 more days.
Yeah.
I'll.
And it is a request to the new president, Dr. Sanjay Pakmode
Yes, ma'am.
sir. So we can have different presenters from different zone of Maharashtra
Yes,
every
yes.
month. And there are a lot of enthusiastic practitioners also. Please contact them and let us
Yes,
know
yes.
in by 15th of every month, so that we get enough time
Yes.
for taking practice and choosing the topics.
Yes, ma'am.
Okay.
Point well taken.
I request Raigad IIP President Dr. Vikas More to give vote of thanks, or Secretary Dr. Ajay Kori, if possible.
Dr. Chitra Madam, just to add,
Yes, sir.
because our president is there, my IP president is there. Dr. Sanjay sir, we have 5 zones of Maharashtra. So
Yes, sir.
once you must have decided a person who is a scientific convener or convener, whatever. So we can have 5 zones, and so 5 zones, so 5 months, so 2 months to each zone, so 10 months,
Yes.
and then 2 extra months. We can decide well in advance, so it will be beneficial to pass out the articles and this. So you
Yes,
can,
sir.
I will send you the message of zones to you, so you can just go through it and just you can contact those IIP branches, sir.
Yes, sir. I had already that list.
Yes.
And
Okay, sir. Thank you, sir.
thank you, sir. Thank you for your
I think so.
advice.
Both are not there, Chitra Madam.
Yeah,
So,
thank you very much.
so
Now,
thank you very much, both presenters You want to ask, you want to say something, Chitra madam? Or I will
No, sir, please give vote
So,
of thanks
lots of
from
thanks.
Raigad IIP.
Thanks a lot, both presenters, Dr. Hari sir, as well as Dr. Dr. Ashish, as well as both experts, Dr. Tushar Godbole sir, as well as Dr. Vishram. He has to leave in between for emergency meeting, but thanks a lot, our mentor, Dr. Nimen Monti, आमचे सर्व आहेत सर आणि thanks a lot, Maha-IP President Dr. Sanjay sir, to accept our request and continue this journey in your year also. We are extremely thankful for that, as well as Secretary Dr. Amol Pawar in absentia, as well as all the EBs who came in between but just left. Dr. Sanjeev Joshi was there, Dr. Rajesh Kulkarni was there, Dr. Sanjay Deshmukh was there, and Dr. I think so.
Praveen Gokhale.
Praveen Gokhale sir was there. So thanks a lot to all of them and all the attendees, as well as the here who are there up to this last moment. I can see their names. I can just thank them because they are very few. Dr. Nutan, Dr. Pallavi, Dr. Ajay, Dr. Sham, all, and thanks a lot, Dr. Thanks a lot. She has become doctor because our 4 years she's with us, Pallavi Dharmadikari and technical team for helping us around. And thanks a lot once again. Happy New Year to each one and everyone. And good night and thank you very much.
Thank you.
Yes,
Thanks,
sir.
sir.
Thank you. Thank you.
Thank you very much.
Thank you,
Pallavi ma'am,
Ganguly.
recording stop.